Ik denk dat je niet zo vreselijk veel macht hebt om dingen anders te laten gaan. Het gebeurt gewoon.
Maar ja, ik ben wel blij dat ik gewoon nog leef natuurlijk.
On voit l'être aimé, complètement distordu et il est là, il est plus là, mais en même temps il est là.
Quando hai alle spalle un dolore, una sofferenza del genere, apprezzi anche le piccole cose. Non è scontato niente, non è scontato che respiri, non è scontato che stai in piedi e cammini, puoi correre, non è scontato vedere il sole, non è scontato niente.
Bijna verdwaasd rond, in een trance rond. Maar ik moet zeggen, de zorg eromheen is wel heel erg goed. En ja, het was een heftige tijd, maar wel een mooie tijd.
Welke gevoelens ik heb ervaren. Ja, je bent ontzettend nauw betrokken bij mijn vrouw, wat die meemaakt. En je kunt daar niks mee, maar je moet er zelf mee uit de voeten. En je hebt wel het volle vertrouwen, dat had ik wel steeds.
Io sono un medico di terapia intensiva, non un rianimatore, nel senso che lavoro con i neonati, quindi mi occupo di tutt'altra di bambini molto molto piccoli, non faccio il loro stesso lavoro, però chiaramente il rapporto con i medici è stato condizionato anche dalla mia posizione. Tra l'altro sono dei colleghi perché sono nel mio stesso, quindi da una parte ero sicuramente facilitata nel comprendere razionalmente quello che stava succedendo, cioè non avevo bisogno dei lunghissimi colloqui perché mi spiegassero per avere notizie cliniche, perché era più semplice riassumermi le cose. D'altra parte, dal punto di vista umano, dal punto di vista emotivo, questo non è servito a niente, anzi forse ha peggiorato le cose, perché sapevo cosa poteva succedere e non volevo accettarlo.
Ahora lo que me motiva es mejorar la vida de la gente. Ya no es tanto la técnica, ¿no?, como cuando eres joven, porque llega un punto que la técnica es técnica y no tiene ningún secreto, sino las pequeñas cosas que pueden hacer que marcan la diferencia. El hablar con el paciente, con la familia, el hacer una educación sanitaria que nadie ha hecho hasta ese punto y tú no lo sabías porque dabas por hecho que lo habían hecho. Esas cosas son las que te motivan, el mejorar el cuidado del paciente.
Il faut faire du cas par cas, en fait. C'est primordial. Parce que chaque histoire est différente. Et quand vous vous trouvez en tant que patient, en tant que famille de patients, dans cette situation, dans un univers où vous ne parlez pas cette langue-là, cette langue faite d'acronymes et de termes techniques que vous ne connaissez pas, quand vous vous retrouvez face au savoir et que du coup vous vous retrouvez impuissant, que vous vous retrouvez stupide, que vous vous retrouvez humilié, que vous vous retrouvez démuni, comment faire?
Jokainen lääkäri varmaan pelkää komplikaatiota tai jotakin, että mitään ei hiffaa jotain juttua, mitä olisi pitänyt hiffata, joskin siinäkin auttaa se, että harvoin tekee yksin koko päivää töitä. Nämä tuli nyt äkkiseltään mulle mieleen.
And what scares me is that making those decisions and making those wrong decisions and the realization that that decision in 3-4 weeks' time, where you end up having a patient who, in effect, can be crippled by life-sustaining therapy, which may not have been in their best interests or the family's best interests. And that still scares me. And I think it scares a lot of colleagues, but intensive care is much more multidisciplinary now, and I think that has helped our decision-making and has reduced that fear factor.
Honesty and humility go a long way. And most patients and relatives understand that we're also human and mistakes can happen and should be openly discussed.
Οι ασθενείς όμως έρχονται σε επαφή με εμάς, ιδιαίτερα αυτοί που βγαίνουν από το νοσοκομείο, πηγαίνουν σε κέντρα αποκατάστασης και ύστερα από πάρα πολύ καιρό έρχονται να μας συναντήσουν, γιατί ξέρουν τα πρόσωπά μας, τις φωνές μας, τον αγώνα που δίνουμε μέσα στο χώρο για να καταφέρουμε να τους σώσουμε, να επιβιώσουν και έρχονται να μας δουν, να μας γνωρίσουν από κοντά, να τους δούμε κι εμείς.
Together with my colleagues, in particular the nursing colleagues, we arranged a wedding for a patient who was at the end of his life and had decided to marry his long-term partner before he later died. And it was very moving to be part of this very special event in the intensive care unit.
It's a real privilege to be able to support a patient and their family through that what I hope is the worst thing that ever happens to them in their lives, to be able to support them through that, hopefully to recovery, or to support them through managing a dignified death.
Il faut ramener la vie. Pourquoi est-ce que tout est si blanc et voire gris? Pourquoi est-ce que ce lino couine autant sous les crocs des médecins? C'est insoutenable. Pourquoi est-ce que tout était autant aseptisé? C'est pas 3 photos qui vont empêcher les gens de travailler. Moi, je pense que c'est important de ramener de la vie à cet endroit où on se trouve à la frontière au bord d'eux, on se trouve dans une espèce de no man's land où on sait pas sur quoi ça va déboucher, quoi.
La mia opinione della terapia intensiva è fantastica perché mi hanno salvato la vita e dopo 3 anni sono qui. Anche a un altro ospedale che mi hanno dato per morto, per fortuna sono arrivato a questa terapia intensiva e mi hanno salvato veramente la vita.
Solo belle cose possono uscire dalla mia bocca, ovviamente, perché senza di loro non sarei qui, ripeto, non sarei qui oggi.
Intensive care medicine allows me to learn something new every day. So every day I meet colleagues and I hear of their new technologies, new advances, and progress in their particular specialty. But most importantly, every day is a different day with new challenges, and I enjoy the interaction with my colleagues and most importantly with patients and their relatives. So it provides a great variety, it's different every day, and it's a specialty where progress is made on a regular basis.
Grazie perché mi hanno ricordato anche come si lavora. Cioè, io faccio questo mestiere, lo faccio da tanti anni, ci sono dei momenti in cui sei stanco, in cui hai le tue cose, nel senso che hai la tua vita, hai delle preoccupazioni, però io ero serena quando andavo via, non perché sapevo che non sarebbe morto, poteva morire, poteva star male, ma era nelle mani migliori. Sapevo che era nelle migliori mani e questo mi dava quel minimo di tranquillità che potevo cercare. È giusto che i bambini che mi vengono affidati e i genitori quando vanno a casa possano pensare la stessa cosa. Siamo nelle migliori mani, quindi dobbiamo sempre fare il meglio. Grazie a loro per esserlo il meglio.
So I am a full-time intensivist and proud to be one. We're all working together in a multidisciplinary fashion to fight COVID-19. Together, we are intensive care medicine.
Hello, I'm internal medicine specialist and I'm proud to be an intensivist. We intensivists are working hard to fight for COVID-19. Together, we are intensive care medicine. Thank you.
I am the editor of Intensive Care Medicine Journal and I'm proud to be an intensivist. We are working together to fight COVID-19 and to take care also of non-COVID patients. Together, we are intensive care medicine.
I'm a nephrologist and I'm proud to be an intensivist. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
I'm an anesthesiologist and I'm proud to be an intensivist. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
Good afternoon, everyone. Welcome to this webinar on de-escalation. And I will start with a short introduction before we get to our speakers today. So my name is Jeroen Schouten. I'm an ICU physician at the Radboud University Medical Hospital in the Netherlands. I've been involved quite a lot in infectious diseases and in antimicrobial stewardship as a fact. And when I was training as a medical resident, I do remember that one of the first things I learned was, well, you have to revert back to narrow spectrum antibiotic therapy as soon as you can. I was still a medical internal resident at that time, and it seemed really pretty easy, right? I didn't really think it was a brave thing to do or something, that was very special. But then I started working in the ICU, and more I became aware that it's actually quite a challenging thing to do with a different set of patients with multiple organ failure, frail outcomes. And suddenly de-escalation became far more than that. It became a totally different ballgame. And I feel it's still a very interesting topic for ICU. Antimicrobial stewardship requires much more than you would think about it at first, right? So knowledge about microorganisms, how representative a sample is, where the culture was taken from, etc. There's a lot of things to say about it. So I'm very happy to discuss, to be able to discuss this topic with you today, especially with Alexis TABAH and with Lisbeth de Bus, who have a special interest in this field, a special expertise in antibiotic de-escalation. And I consider them, well, probably the ones within our field that have the most of knowledge on this subject at the moment. So I'm a little bit nervous about it, but let's get started. We have one presentation on really the background, the theory of antibiotic de-escalation by Alexis TABAH. And we have one by Lisbeth that is called ADE, de-escalation in the critically ill, what we do and how we do it. So we start with Alexis, and Alexis, all of you who don't know him, Alexis is a clinical researcher and an ICU specialist who works in Australia now, in Brisbane, Australia. He has a French background. He was the lead author of a position statement that was published last year on antimicrobial de-escalation, and he currently leads a large project, I think it's even a larger project than the first one I mentioned, a multinational cohort study on hospital-acquired bloodstream infections. So I'm very excited that he would be the one to talk to us today as the first one. And I would like to tell you one little thing about how we're going to do this. So during the presentation, Alexis will provide you with some examples, with some cases. And we want you to think already very hard of that, because we'll let these same cases come back at the end of the second presentations by Lisbeth. So we want to see how much you have, if you will, changed your position or changed your mind on this. So thank you very much. If you have any questions, use the chat. And I'm now going to stop because I'm going to give place to Alexis. Alexis, welcome and thank you very much.
Hi, so thank you, Jeroen, for the kind introduction, and thank you very much to everyone who joins the webinar. So indeed, I'm going to do the first part to discuss the rationale behind de-escalation and see how it is defined. So a few disclaimers. I think we already know that antibiotic administration causes emergence of resistance to antibiotics. And one of the things that we will not discuss in this webinar is the choice of the empirical antimicrobial therapy or its timing, because even if they are very important, they're a different topic for a different webinar, and de-escalation comes after. And the other thing is that I have absolutely no conflicts of interest. So de-escalation is an important component of the antimicrobial stewardship strategy. And if you look at any guidelines on sepsis, septic shock, any sort of infection, organ-specific, they will at some point discuss de-escalation. And it's interesting to see in our surviving sepsis campaign that they recommend daily assessment for de-escalation with the best practice statement, which highlights the low level of evidence that we have for this very important topic. So the rationale for de-escalation, I see it as a way to try to safeguard the harm that can be done to the ecology by the broad spectrum antibiotics that we need to use. So we have patients with severe infections and a high risk of death. And at the time of choosing the treatment, we don't know the pathogen. It could be a multi-drug resistant bacteria, depending on the setting. And we need to give them antibiotics that could treat any likely pathogen. So with that comes a risk of an increased risk of emergence of resistant pathogens, and we'll use de-escalation as a mitigation strategy. So as I said, we know that antibiotics cause resistance, and this quite recent paper by Thesum is interesting because they looked at the cumulative exposure to anti-pseudomonal beta-lactams, and they looked at how the resistance emerges in patients that receive that on time brackets, and they show that the longer you give antibiotics, the more resistance you will get, and that there is no ceiling effect. So the longer you keep going, the worse it may be. So de-escalation could be a simple way to prevent resistance, right? We start broad spectrum antibiotics, we receive our micro results, and we de-escalate to narrow spectrum. So yes, but it's not so simple, as Jeroen said, and we'll start with a few fictional examples that we will have the opportunity to discuss at the end of the webinar. So the first one is a neutropenic patient with septic shock. There's no clinical source of infection other than his podacat that is swiftly removed and is treated with meropenem, vancomycin, and gentamicin. He goes to the ICU and he clinically improves rapidly. And after a few hours, we already have positive blood cultures with gram-positive cocci. And on day 2, we know that it's a Staph aureus that is susceptible to methicillin. So we would like to know what would you do with these antibiotic treatment here. The other case that I would consider as more complex is a 50-year-old male, fit and well. He comes for peritonitis, colon perforation, has a resection, anastomosis, and is treated with piptaz and amikacin. Gets better, and at day 7, there's a new deterioration, and he's admitted to the ICU with septic shock, anuric, needing ventilation, and the reoperation finds a suture breakdown, and there he is treated with meropenem, vancomycin, and amikacin. We've got some blood cultures that show a gram-negative bacteria that will turn to be a E. coli, resistant to ceftriaxone and susceptible to piptaz, and we also have some intra-op specimens with mixed enteric bacteria, and the clinical course shows some improvement, but is still critically ill. So again, what should we do with the antibiotics here? And the third case is a urinary source of a bloodstream infection with a Pseudomonas that is susceptible to all the antibiotics that it's supposed to be. It's treated with high-dose piptaz, and there's a discussion about changing him to ciprofloxacin, maybe oral ciprofloxacin after a while. And how would we rank that? Escalation, de-escalation? I think that's one of the complex questions about de-escalation. So how do we define antimicrobial de-escalation? I'm going to try to give you a bit of a sense of the discussions that we had when we made that statement. There were 16 experts, and we made 13 statements through this document to provide a guideline on how to do de-escalation. And one of the striking things is that there was only one randomized controlled trial and a small one, and all the rest were observational studies, so not much strong evidence. So a lot of controversy, and we used the Delphi method to achieve the statements. One of the things is the way we look at the concept of how the empirical antimicrobial treatment is structured. So there's a pivotal antimicrobial, that's the main drug, or some people call it the backbone antibiotic. It's very often a beta-lactam, not always, but often. And to that, you can add some companion antibiotics. Some can be given for an extension of the spectrum to treat some organisms that wouldn't be covered by the other one, such as anti-MRSA agents, antifungals, agents to treat intracellular pneumonia, or other antimicrobials can be given for very specific effects, such as antitoxin effects for lincomycin in necrotizing fasciitis. So this is started at the empirical treatment. That's a time of uncertainty, and we want to know what to do when a bit later we have more certainty, culture results, some clinical progress. So that's what we're looking at. And if we look at how is de-escalation defined in all the studies that treat about de-escalation in intensive care patients, so we had 23 studies, and most of them agreed that giving fewer drugs would be de-escalation. Likewise, everyone say that giving a smaller spectrum of a drug would be de-escalation. And interestingly, half of the studies provided a ranking to what means broader or smaller spectrum, and half of them just said de-escalation to a smaller spectrum, as it makes sense what it is. And a third of the studies included early cessation of all the antibiotics in the definition of de-escalation. So this is the definition that we provided in the statement, is that antimicrobial de-escalation is defined as replacing a broad with a narrow spectrum antibiotic and or to stop a component of combination. And we specifically said that early discontinuation is not de-escalation. I think that's a point of controversy, so I'm going to try to explain why we came to that conclusion. And I think we have quite some evidence now that shorter treatments are better, and that we should not continue antibiotics when the patient does not need them. And I think that's the important point. So we put a lot of value in stopping the antibiotics when they're not needed anymore. That's why we did not want to confuse things. We think that stopping a treatment is one thing. So when they're not required, they should be stopped and not continued with a narrower spectrum drug. So de-escalation is a different thing, is when you still need an antibiotic, but you got an opportunity to change it for something different that will cause less harm to antimicrobial resistance. So if we start with the companion antibiotics, because I think that's the easier part of de-escalation, I think all those studies, what they've shown is that it's very safe to stop antibiotics when they're not required and to de-escalate the companion antibiotic. So I think we can say if there's no MRSA, we should not continue the vancomycin, and if there's no invasive fungal infection, we should not continue the antifungals. In some cases, the companion antibiotic will become a pivotal antibiotic. Again, if you think of the candidemia, that's what started on antibiotics and antifungals, then you will stop the antibiotics maybe, depending on the source and the clinical setting. I think for the spectrum of the pivotal antibiotic, it's more complicated. And I'd like to refer to this letter that Jacques Accard wrote in CMI in 1997, and it's still very relevant. And his title was Broad and Narrow Spectrum Antibiotics, an Unhelpful Categorization. And he went to explain how we came to use this word of de-escalation, and that the industry pushed it as a way to give a sense of safety when using those agents. And I think the important thing for our topic here of de-escalation is that while there's a relationship of the bacterial spectrum of how many bacteria are susceptible to this antibiotic, it's not a linear relationship with the ability to select resistant organisms. There's much more to it, and the mechanisms of action of the antibiotic and how resistance is developed are very important and different. And is there any low-level resistance in your bacterial population? What's the site of infection? What are the other species? The other drugs that are given at what concentration? So there's many things that will come into account. And if we want to look at a more up-to-date or modern view of the importance of de-escalation, we should look at the intestinal microbiota and the concept of colonization resistance. And I've taken this beautiful graph from this review from Vorter and colleagues in the AGAA, and I've put the reference there because I think it's really interesting the way they explain this. So we have the intestinal microbiota that is a very diverse bacterial population that is made mostly of anaerobic bacteria, not only, but mostly, and that occupies the niche in our gut and creates this colonization resistance, and that prevents pathogenic bacteria from taking hold, prevents the multi-drug resistant bacteria from taking hold. So if we give antibiotics to treat our patients, that will cause some harm to colonization resistance. If those drugs have biliary excretion, that will cause more harm because they concentrate in the stool. And if those drugs have anti-anaerobic activity, also it will have more harm. So with antibiotic de-escalation, we will try to protect this colonization resistance. If we look at what happens to ICU patients, Laurence Armand-Lefebvre showed 8 years ago now that after 1 to 3 days of imipenem, ICU patients were already developed significant resistance to carbapenems, and that increases with a longer duration of treatment, but a lot of harm is already done very early in the course. For piptaz, I think it's important to know that it has a lot of biliary excretion, and we learned last year at Lives that it can be detected in the stool of some patients up to 6 days after the last dose. So probably there's still some harm at the end of the treatment when we stop and change the drugs. So I think it's a very widely used drug, and we should be mindful that it's not innocuous. If we want to look at what is the spectrum and how are the antibiotics ranked, there are 2 scales, and Weiss, with a group of 28 French experts, produced a ranking scale specifically of beta-lactam antibiotics and specifically for the purpose of de-escalation. So they provided a very useful scale from 1 to 6, and on the right columns, you can see the number of Delphi rounds they needed to reach a consensus. And if you look at the middle rank, they needed 4 rounds to rank piptaz and extended spectrum cephalosporins. So that really shows how difficult it is to reach consensus, and that spectrum, it's not a very clear concept. There's a lot of things to think about. The other ranking scale that is available looks at all the classes of antibiotics, and that's done by Madaras Kelly on a database of the Veteran Affairs. And what they did is that they took antibiograms of pathogens, and they looked at what pathogens are resistant or susceptible to each antibiotic, and they were able to give numbers to that and to compute a score. So here they provide a score of all or most of the antibiotic classes. so VICE, they took into account also the ecological consequences of giving the antibiotic here. I think it was more directed towards really the spectrum. And it's interesting to see that, you know, the scores of meropenem and Cipro and Doxy are actually very similar. I think what's more interesting is to compare the two scales. So if we take the VICE scale on the left and rank the antibiotics 1, 2, 3, 4, 5, 6, and we apply the Mara-Scully classification to that, we end up with 1, 3, 2, 7, 5, 4, 6. So there's not great agreement between the two scales. And interestingly, piptas and imipenem don't have the same order. And well, that really shows the extent of the problem with providing ranking. So I think if we want to use a ranking scale for our hospitals and our departments, we could go from one of those scales, such as VICE proposed, but we need to look at, you know, the antimicrobial activity of the drug, what are its effects on the microbiota, and also take into account all what is the impact of each drug in our population and what's the resistance problems that we may have in our community. So if we go back to why do we do de-escalation, and mostly we do it to reduce or prevent antimicrobial resistance, I think that other benefits should not be underestimated. So things like toxicity. Nowadays, we got a lot of data coming about the renal toxicity of the combination of piptas with vancomycin. And that's probably a good thing to stop vancomycin when it's not required to hopefully prevent some renal failure. And do we know if de-escalation prevents resistance in ICU patients? Well, of all those studies, there were 6 studies that provided some data on the effects of de-escalation in their cohort. The thing is, none of the studies was prospectively designed to systematically assess the effects of de-escalation on antimicrobial resistance. And I think what, in summary, not to go through each one of the papers, we can say that we don't have great evidence, but we can say that probably yes, antibiotic pressure causes resistance, and de-escalation allows for a decrease in spectrum and a decrease in antibiotic combination days. So probably yes. And I think that there are 2 things that I would like to see as 2 studies. And the first one would be to see what are the sequential effects of antibiotics on the microbiome and on colonization resistance, you know, to try to understand what is the effects of changing antibiotics, of the overlap of different drugs and their concentrations on our microbiome. And the second one would be a large cluster randomized study where we assign a strategy of de-escalation or continuation for a period of time to each department, and we see what's the effect of the ecology. And I think we need those 2 things to progress in our discussion about the effects of de-escalation. So with this, I've said all what I wanted to tell you about the definition and the rationale. And I leave you with this concept of the empirical treatment, and remembering to take some cultures, and that we will need to discuss what we do with the antibiotic regimen after a couple or a few days. And I will leave the microphone to Lisbeth now. Thank you very much.
Thank you very much, Alexis. And I already can think of a lot of questions I want to ask you, but I'm not going to do that because I think it's wise to just now move on to the next speaker. But before I introduce the next speaker to you, I would like to stress that you can provide some questions in the chat, and don't be shy. Anything that you ever wanted to ask someone on de-escalation can now be asked, and so there's no stupid questions, and I've noted them all down, so we will discuss them after the second session. So that gives you time now to introduce Lisbeth de Bus, who is also an internist and intensivist working at the hospital, the University Hospital in Ghent, and I was so lucky to be present at her PhD dissertation 2 years ago, where she actually her dissertation was called "The Use of Computer-Assisted Registration Program to Investigate Antibiotic Prescription and Resistance in the ICU." So there already she got a good view on what happens in a large university hospital related to antibiotic de-escalation, but also she co-led the Diana study, and I'm sure you know about the Diana study, which was an ESICM endorsed international study that looked at antimicrobial prescription in general, but also very much at de-escalation practices in European and worldwide hospitals, actually. So a very good experience and a very good starting point for Lisbeth to talk about the more general aspects of ADE, what we do and how we do it. So Lisbeth, the floor is yours. Thank you very much.
So thank you very much, Jeroen, for this introduction. And I would also like to thank the European Society for giving me the opportunity to give this presentation, of course. So these are the aspects that I would like to address during my presentation, what we do regarding empirical antimicrobial prescription and de-escalation, how we do it, where does it lead us? Then I would like to address some specific populations. I would like to share some lessons I've learned, and then we will come back to our example patients, and we will see how your opinion may have shifted during our talks. So indeed, between October 2016 and May 2018, we ran the Diana study, a multi-center international cohort study, observational, in adult critically ill patients that were prescribed empirical antimicrobial therapy for a suspected or confirmed bacterial infection. And we were able to include almost 1,500 patients. Before we can talk about de-escalation, we had to look into the empirical antimicrobial prescription. And what we prescribe in our ICU patients remains very close to the concept of a pivotal and companion antimicrobial components, as alluded to by Alexis. So in 50% of the included patients, monotherapy was prescribed. And as you can see, beta-lactams indeed represent the backbone of our prescription. So the other 50% is a combination therapy. And of course, again, the beta-lactams there as the backbone of the empirical prescription. But here they are prescribed together with the well-known companion antimicrobials, such as the glycopeptides in the first place, but also the macrolides and the aminoglycosides. So defining de-escalation for the study was quite a challenge, especially in a multi-center international setting. And we tried to align our definition as close as possible with the consensus definition that was provided by the task force. So the first scenario was straightforward, a discontinuation of one or more antimicrobials of an empirical combination therapy that was considered by the treating physician to be not or no longer required for the treatment of the infection under study. The second scenario was a lot more difficult, as said in the previous talk. A numerical score to define and guide de-escalation is not yet available. So what we decided was that we wanted to capture the intention of the physicians to narrow the spectrum, and so we would see what is happening in real life practice. In addition, we said that these treatment changes had to take place during the first 3 days of empirical therapy, and day 0 being the start date of the treatment. So what we saw was that de-escalation, as it was defined in our study, was done in 16% of the included patients. And this was a number that was unexpected low, surprisingly low, when we compared it to the figures that we knew from previous literature, which were between 25 and 81%. So there was also a lot of discussion regarding the timing of de-escalation. So the task force recommends to try to de-escalate within 24 hours of definitive culture results and antibiogram availability. And what we did is we decided to evaluate the effect of an extension of our de-escalation time frame to day 5 and day 7 respectively. And we saw indeed it would increase the number of de-escalated patients, of course, but only with a small amount to 21 and 23% of prescriptions. Unfortunately, we only collected the motivation of the ICU physician why to perform de-escalation, but not why not performing de-escalation. So we have no firm explanation for this lower than expected de-escalation rate. How do we do it? In our study, de-escalation was mainly performed by discontinuation of a component of combination therapy. So in 52% of cases, 1 out of 3 patients were de-escalated by the intention to narrow the spectrum of activity, and in 13% both strategies were used. When we looked more into detail to the components that were discontinued within a combination therapy, again, not unsurprisingly, we saw the glycopeptides, the aminoglycosides, and the macrolides as top 3 agents. So as said by Alexis, we also think this is the more easy way to do de-escalation. Narrowing the spectrum of activity, on the other hand, has proven to be much more complex. And here you can see the top 5 of switch scenarios that we recorded in our study. And if you look into the figures here, you can see that they are much smaller than on the previous slide. And when you look to the supplementary material of the Diana paper, you can find over more than 50 other treatment scenarios that were reported as being an intention to narrow the spectrum. This gives an idea about the very complex treatment scenarios in our ICU patients. So as I said, we also reported the motivation of the physician why to do de-escalation. And if we look into the discontinuation of a component of combination therapy, then we see that this is driven by the presence of positive microbiology, but also by the absence of certain pathogens. So the absence of certain pathogens that are targeted by a companion antimicrobial may drive discontinuation. But this is not the case when we look into the intention to narrow the spectrum. Here we see that microbiology has a very important role, and the presence of positive microbiology drives de-escalation here, and negative culture results are rarely mentioned as being a driver for the de-escalation. In his systematic review on the determinants of de-escalation, Alexis and his team included 2 randomized controlled trials and 12 cohort studies. And factors that were positively associated with de-escalation were an initial appropriate antimicrobial therapy, broad spectrum, and treatment with multiple and companion antimicrobials, compliance with guidelines, positive microbiology, and low severity scores of illness. On the other hand, isolation of multi-resistant pathogens, polymicrobial infections, and intra-abdominal infections were negatively associated with de-escalation. So applying this knowledge again to the Diana results, we could also confirm that the infections were much more microbiologically documented in the patients that were de-escalated compared to the patients that had no treatment alteration during the first days. Also less bacteremia, of course, in the de-escalated patients. But in contrast with the report of Alexis, the number of patients with a polymicrobial infection was similar in both groups. Combination therapy was prescribed more often in the de-escalated patients. And here you can see a table where I show a link between empirical combination therapy and the de-escalation rate. So I've blinded the names of the countries, but it's quite clear and obvious that prescribing empirical combination therapy facilitates de-escalation later on in the treatment of the patient. And finally, the severity of illness, also very interesting. De-escalated patients presented more with septic shock at the beginning of the infection, but they also showed more clinical improvements as expressed in a delta SOFA score during the first days of treatment. In addition, the de-escalated patients had more need for source control, but when source control was required, it was more often effective in the de-escalated patients. So we presumed that patients that were more severely ill at presentation were prescribed more combination therapy and more broad spectrum therapy. However, in the case of a favorable clinical evolution, they were also de-escalated more easily. So now I would like to discuss some of the important clinical outcomes of the patients. So also in the systematic review by Alexis, they found that there was an association between de-escalation and a better patient outcome regarding mortality. However, in this analysis, only one randomized control trial was included, the trial from the group of Leone. And in this trial, there was no mortality difference reported. However, this trial was underpowered for this endpoint. On the other hand, the investigators could not show non-inferiority regarding their primary endpoint, which was length of stay in the ICU. Multiple cohort studies were included in the review, however, with a high risk of bias, because the escalation was mainly performed in the improving patients. So, in conclusion, we may assume that de-escalation is safe regarding the aspect of mortality. However, we have to be cautious with saying that it may improve patient outcome because this risk of bias. In the Diana study, we looked into survival and clinical cure on day 7 as primary endpoint, and what we tried to do was to adjust for confounding factors that vary during the time course of the infection. So we tried to control as much as possible for factors that affect both the decision for the escalation and our outcome, which was clinical cure. Again, we found that de-escalation seems safe regarding our primary endpoint, but once more, we have to be cautious because also in our study, residual confounding is very likely. Then de-escalation in some specific patient populations. I would like to look for what is known about de-escalation for resistant pathogens. So the task force recommends that recommendations for or against de-escalation are similar for all bacterial pathogens, except for the difficult to treat resistant pathogens in patients with a high risk of death. It was a moderate recommendation with a low quality of evidence, and this was mainly based on somewhat indirect data. First of all, the data coming from the Merino trial, which was a non-inferiority randomized control trial. They included patients with an E. coli and a Klebsiella pneumonia bloodstream infection, where the pathogen was ceftriaxone resistant but PIPTA susceptible. And they compared treatment with piperacillin tazobactam versus meropenem. And non-inferiority regarding 30-day mortality was not confirmed in this trial. So the authors concluded that piperacillin tazobactam was not really supported in this setting. However, additional trials are running, and we will see if these statements hold true in the future. Then other data come from the Increment, which was a retrospective international cohort study. They included monomicrobial bloodstream infections with carbapenemase-producing Enterobacterales. They used the Increment CPE mortality score, which divides their patients into a group of patients with a high mortality and a group of patients with a low risk for mortality. And an evaluation of appropriate combination therapy versus appropriate monotherapy showed a protective effect of combination therapy in the high mortality score group. Also here, new well-designed trials will be required in the future. And these new trials also have to include the more novel beta-lactam-beta-lactamase inhibitor combination to determine their role in the treatment of these difficult pathogens. De-escalation for invasive candidiasis is recommended by the task force following clinical and microbiological resolution, and if pathogens are, of course, susceptible to azoles. This is a strong recommendation with a low quality of evidence. So these are based on multiple studies, but very importantly is when we think about de-escalation from an echinocandin, which is a preferred empirical therapy for invasive candidiasis, to an azole, we have to know that in all these trials, the patients that were de-escalated were clinically stable patients with negative repeat blood cultures, of course, azole susceptible candida, and following at least 5 days of echinocandin therapy. And in the neutropenic patients, they state that de-escalation can be applied with a weak recommendation and a low quality of evidence. The research supporting this recommendation in our ICU cohort comes from the observational study of MOCAR, which included over 100 neutropenic cancer patients that presented with severe sepsis and septic shock. And they saw that 30-day mortality and mortality 1 year after ICU discharge was not worse in the de-escalated patients. So with this, I would like to conclude with some of my lessons I've learned. In my opinion, optimization of antimicrobial treatment and potential future de-escalation starts already before the empirical prescription. So it's very important before you prescribe your antimicrobial that you do a good diagnostic workup. You look for source control as much as possible, and you do an adequate microbiological sampling. Because we've seen in the previous slide, the presence of microbiology really supports de-escalation, really promotes de-escalation. Besides that, it's also important to have a good patient history and a well knowledge of the local ecology in your hospital, because future de-escalation may not be an excuse to start your most broad spectrum available antimicrobial therapy if this is not necessary in your patient. Following the empirical prescription, you have to do frequent and scheduled reevaluations during the clinical course of your patients. Go again over the diagnostics, the source control, and do multidisciplinary meetings where you integrate all components and also, very important, predefine the duration of your antimicrobial therapy. And in case no infection is present and you have an alternative diagnosis, I think it's quite safe to stop all antimicrobial treatment. If an infection is present, then the discussion can begin. How long will we treat our patient, and how will we streamline our empirical treatment? Will we perform antimicrobial de-escalation? So, and with this, we will go back to our example patients. So I will present them once more. We had our first neutropenic cancer patient who presented with methicillin-susceptible Staph aureus in the blood cultures and was empirically treated with meropenem, vancomycin, and gentamicin. What would your suggestion be? And then the more complex patient, the 50-year-old male fit patient presenting with septic shock, but reoperated and deteriorated following a suture breakdown, then empirically treated with meropenem, vancomycin, and amikacin. And bloodstream infection is present with E. coli sensitive to piptase. What will we do here? And finally, the urinary source, bloodstream infection, with a Pseudomonas aeruginosa, which is pan-sensitive, where we can choose between the treatment options of piptase or ciprofloxacin. So, and with this, I thank you for your attention, and we can go to the discussion.
Okay, thank you very much, Lisbeth. That was a very, very nice talk and a very nice oversight of the literature. Let's go back into the presentation just once and look at the first case. Can we still get that online, please? Because this was a patient, a neutropenic patient that could be de-escalated, I guess. And I'm just going to ask Alexis the question: what is it that you would do in this patient? Would you first of all, would you change therapy at this stage, and if so, would you, to what kind of antibiotic or class would you change?
So I think, yes, I would absolutely change when I have the results that it's MSSA. I would wait at the time where there is a positive blood culture, because I know that more results will come the day after. And I think one of the problems we have in our clinical work is when, the clinical course is always, it's never linear, and the patient will improve and deteriorate again. And I think the worst we can do is change antibiotics every day. So I think we need to really observe and make a rational decision and change the antibiotics. And that's why we said de-escalation should be done at the time where the definitive culture results are available, within reason.
Okay, so that means that at this stage, at this stage you have a day 2 sensitive Staph aureus. Would you dare to change to methicillin or flucloxacillin?
I would change that patient to cefazolin only.
Yes.
Or fluclox. Yes.
Okay. That's a good option. Is that also something that you would do, Lisbeth, or would you say, well, this patient's still neutropenic? I don't know. Maybe something else going on. He could have something else going on at the same time.
As the patient is really clinically improving, and we have really this blood culture. Also in our setting, we would switch to fluclox, indeed. Indeed, the fact that the neutropenia is there, but yeah, no, we would switch because we have the blood cultures here, we have the susceptibility pattern, and we really would go to fluclox. Yeah.
Yeah. Well, I would agree with all of you, and I think this is an excellent example of where it is actually quite clear what you can do. Just a short interest, Alexis, why cefazolin and not a penicillin?
Either I think would be valid. I think there's been some data that cefazolin is at least non-inferior to fluclox.
Yeah. Okay, thank you. Yes, I think it would be very interesting to do a side-to-side, to do a comparatory trial between the two directly for Staph aureus bacteremia, for example. But that's something that still needs to be done. I think maybe I'm just taking some questions now that I get from the audience. One person in the audience mentioned the use of biomarkers, and so I was just curious, and maybe you can start, Alexis. In this patient, would PCT help you to decide about de-escalation?
Well, I would like to answer several things. The first one is that within the statement, we had 2 experts looking at biomarkers, and they answered that there was no literature looking at biomarkers with regards to de-escalation. There's good literature on procalcitonin that may be useful to stop antibiotics, but not de-escalation. The second answer is that in my clinical practice, we do not use biomarkers. And I think they tend to confuse things more than anything.
Yeah. So and in terms of what kind of biomarkers, BCT, presepsin, Lisbeth, you have some experience. Would you like to comment on what biomarker you would employ, or would you also not advocate this in the decision for de-escalation?
In my opinion, also in the decision of de-escalation, it's not proven that there is a role for biomarkers. So we also don't use it in our decision for de-escalation. No.
Yeah, there's quite some evidence that it can be used to stop for early withdrawal, obviously, but that's not the topic today. I want to, because of the sake of time also, I'm going to go on with you, Lisbeth. There's a question from the audience, especially for you, and it does relate a little bit to the topic that we're discussing with MRSA and MSSA, etc. So this is a question from Andrea Ortiz. She asks, in a patient with risk factors for MRSA VAP, without any microbiological identification in the cultures, so the cultures all remain negative, do you still consider stopping MRSA coverage? Is your attitude, that's the first question, would you consider stopping that? And the second question would be if your attitude would be different if the patient is colonized in his nose, so he has nasal colonization with MRSA, or do you actually not consider that at all?
So I think this really depends on the quality of the cultures that you have taken. So we really advocate to try to obtain high quality cultures. So if it's a ventilation associated pneumonia, I think it's quite easy to obtain a BAL or an endotracheal aspirate with a good quality. And in this case, if this does not show the presence of an MRSA, I would stop the MRSA coverage. There is also some evidence in the literature that this can be done. So
Yeah.
I would stop it, yeah. And if there is colonization in the nose or perineal or something like that, but it's not in the aspirate, also then I think it's not necessary to continue the treatment.
Yeah, yeah. Thank you very much. Can we maybe go to the next slide and look at the second case, just as a starter for the discussion? So this was a much more complicated case. Maybe we can get it into the picture. Yes. So a patient with a peritonitis, a septic shock, and here, well, maybe the first thing I would like to ask, it's also a question also for you, Alexis, which was asked by the by one of the speakers or one of the participants. I would like to make a question to Alexis. Should we consider piptazo with a broader spectrum versus meropenem? So what do you actually think is a broader spectrum, piptazo or meropenem? I know we have Cipro piptazo discussion, but what do you think about that?
So, well, no. Personally, I really think that I would classify meropenem as broader spectrum. And actually, I think the vice classification makes a lot of sense to me. And I think this discussion can easily be done within a class of antibiotics. That's why I put Cipro in the other case, because I think it's much more complicated between different classes. But anyway, I think really meropenem is broader spectrum. If we can say that. But then what I really wanted to highlight is that piptaz is absolutely not a innocuous antibiotic. And I have this impression that over the years, it is used more and more as an empirical treatment, and both in the wards and in the ICUs. And there's a sense that, well, this is the go-to antibiotic. And actually, it is probably an antibiotic that causes a lot of resistance to itself, but also to carbapenems. There's some data for that. So that's what I wanted to highlight. And within the case, that's also what I wanted to discuss, because there's a lot between changing those two antibiotics. Lisbeth showed us the Merino trial that showed that de-escalating a carbapenem in ESBL would be likely to increase mortality. So that's one thing also where I think we should be very careful. And the other thing, I choose this case with the peritonitis because we know that when there is source control, we can do short treatments. Probably 5 days is enough. So if we're going to de-escalate this meropenem here at day 3, there are only 2 days of treatment left, and so we're going to change antibiotics. We're going to still have some degree of concentration of meropenem circulating, and then there will be an overlap, and that's for only 2 days left of treatment. And I don't want to say do not do it, but I would like to say this is really something that we need to think about. What would be the benefit of the escalation in this patient? Should I just wait for the end of the treatment at this point?
Yeah, I think you're right. And what I was about to think about another scenario where you, for example, start with ceftriaxone, and then, for example, in pneumonia, you have a patient, then a pneumococcus arrived, and then at day 3, you can change. You could actually de-escalate to penicillin, right? Most pneumococci is penicillin sensitive. But if you think about the microbiome, this is probably not a very good idea. Because you are then destroying all the anaerobes in your gut, and at least the people who believe in SDD feel that that's a very, very bad idea to do. So they would continue ceftriaxone for 5 days rather than changing it on day 3. But thank you very much for your explanation. I'm going to go back to another question. I want to ask Lisbeth about this, and so this is also a question from the audience. So a patient with sepsis and organ failure who stayed in ICU for more than 40 days, requiring multiple parenteral antibiotics during the stay, then finally improved on clinical laboratory parameters and is afebrile now for 3 days. Do we stop all the antibiotics at once, or do we de-escalate to some narrow spectrum oral antibiotic for a few days and then stop? So should we have something, at the end just to make sure?
So it was a long question, but if you think that your treatment course is completed, so then there is no reason why to extend this treatment longer with a more narrow spectrum treatment. Like Alexis said, you still are going to give ecological harm to your patient with extending the treatment with a few more days with a more narrow spectrum agent. So I think you have to continue your treatment until you think it is treated, but not extend it a few days longer just to be sure. And I think we do a lot in our ICUs just to be sure, but we also cause a lot of damage in our patients by doing things like this.
I couldn't agree more. So if you don't have an indication anymore, you stop your antibiotics. And I think that was also the intention of this question. Thank you, Lisbeth. So maybe because we have a few minutes left, people, this was an interesting one, I thought. Well, 2 actually, but let's start with the first one. Alexis, how would you de-escalate when you have no blood cultures available? I even can't do it. This is a question that comes from Ethiopia. This doctor doesn't have blood cultures or results available. Can you still de-escalate, or is that sort of out of the question?
Well, I think that's very difficult. Then you're going to start an empirical treatment based on what you think is the likely pathogen, and probably here you will base all your decision making on the clinical course of the patient and what you know of the ecology, or what are the likely pathogens, and I think there is no. It is difficult because I've not worked in this setting. But how can you know that it is a different pathogen and that you can change the antibiotics? I think you can't. But I would be interested to know from someone who's been working with this setting.
Okay. Thank you very much. And I think it's challenging indeed to do this. I think, again, we have to think about the interaction between de-escalation and stopping. The more we know, the further we get, the more we understand that we can stop early with antibiotics. And that is something to keep in mind, especially in low-income countries. So a final question, I think, because we're running out of time, is a question on, so can we do this alone? Would you consider the consultation of an ID physician especially relevant in de-escalation? Do you need the advice of a microbiologist or an ID physician, or can we do this by ourselves as intensivists? Maybe Lisbeth. Oh, sorry. Go ahead, Alexis, and then I'll let Lisbeth finish.
So I think it's always interesting to do multidisciplinary discussions. I really like the discussions together with our microbiologists. They always have interesting information for us. But not only microbiologists, but for instance, I work in a surgical ICU. Also, the surgeons, they can give some more information about how the operation went, how definite source control is. So I think you have to discuss this decision within your team with different players and actors in that team.
Yeah. I totally agree. And again, de-escalation is a decision that is not only based on the culture, but also on all other kinds of aspects of therapy, like PK/PD, like source control, etc., etc. So Alexis, maybe a final question. I'm just very curious from a behavioral aspect. Why don't people de-escalate? Why do we have so low numbers in this study? 16%. So what is the main driver? What's the main determinant why we don't de-escalate?
So thank you, Jerome, because I think that's one of the things that I'm very, very, very interested in. And I was hoping someday to do a qualitative study on de-escalation, to look at what are the psychological factors that make us prescribe an antibiotic or change it. And one of the things that we see in all the studies is that de-escalation is more linked to the clinical course. So what we can find in the studies is that patients are de-escalated when the SOFA score decreases, which is just a marker of the perception that we may have of the patient getting better, so we feel that we can change our antibiotic treatment. So yeah, I think that there's a lot of psychology in how we're going to behave and start or stop treatments, and that's very interesting.
Yeah, I think so too, and I can tell you there are some studies going on now, also doing qualitative work on this, on stopping and de-escalating, and it is indeed an interesting subject. But I think the most important thing is that people have to look at themselves and try to find out what they do themselves in their own practice. It would be very useful, and also from the Diana study, people could get their feedback on their own hospitals and their own countries to see where they are and see whether they can actually improve. So I'm very sorry, but I think we're running out of time, and I think this was a very interesting conversation where I hope that the participants were have learned a lot and also have maybe rationalized a little bit their opinions about de-escalation, and also have found out that it's still a very difficult subject, but that it's also a doable subject, as Lisbeth has shown. A lot of questions still remain, a lot of research still needs to be done, but as a concept, it will remain a central part of antimicrobial stewardship in the ICU. So maybe some last words, Alexis or Lisbeth?
No, it was a pleasure for me to do this talk, and I hope to do much more research around this topic in the future, because it's gotten my attention.
Thank you very much, Alexis.
Well, thank you everyone who attended the webinar. It was a pleasure.
Thank you very much. Thank you, and thank you to the both of you. Thank you for the technical staff. And we hope to see you again in one of those interesting other webinars that ESICM is organizing at the moment. Thanks.
Thank you. Bye-bye.
Bye.